as we're following this patient, they are continuing to need phlebotomies, they're continuing to have symptoms. So the individual really is not adequately controlled with a phlebotomy and aspirin. And to some degree, that's not a surprise. This individual presented with a fairly aggressive portfolio of counts and symptoms, and is appropriately started on hydroxyurea a day at 1,000 milligrams a day. Let's say the goals of that include several things. One, can we decrease that rate of phlebotomies, or get an individual to really where it is just the rare occasional phlebotomy? I don't know whether it's necessary for a patient to have 0 phlebotomies, but over time I think they should really be quite infrequent. Otherwise, to some degree, it's a sign of overly active disease. The advantage of medical therapy with cytoreduction with hydroxyurea includes not having to make the patient be as severely iron deficient. Phlebotomy really is iatrogenic iron deficiency. That's the only reason it helps to control the counts. And like any other therapy, iatrogenic iron deficiency is quite variable as to how well a patient tolerates that component. Now, a limiter of iatrogenic iron deficiency as the therapeutic goal is that it frequently is disappointing for controlling splenomegaly or certain symptoms, and sometimes will exacerbate other symptoms by adding to fatigue, restless leg, or other difficulties that can arise. This individual, I would say, again, remains more in that intermediate risk sort of category. They have cardiovascular risk factors. They are under age 60. They've not had a thrombotic event, but they are highly symptomatic, and they are not tolerating phlebotomies well. So although intermediate would be very consistent with our current NCCN guidelines for consideration of cytoreductive therapy. The decision when to make hydroxyurea or cytoreduction part of the therapy includes a dynamic monitoring of the patient. The historical way that polycythemia vera was managed, which was solely the initiation of cytoreduction on the basis of being high risk, I think was really inadequate. That historical, quote, high risk had to do with what was your risk of developing a thrombotic event. It did not correlate with how well you felt with the disease, how well the disease was controlled, or how much the patient was suffering with the disease. So I think it really was a very partial view of the burden the patient was facing. It was in that spirit that our current NCCN guidelines view that low and intermediate risk patients may too benefit from cytoreductive therapy in certain circumstances. And that can be not tolerating phlebotomies well, or having difficult symptoms, or having difficulties with splenomegaly, some of which all are represented in the case that we have before us. Now, when we begin hydroxyurea therapy, as I share with patients, most patients with polycythemia vera who are managed with hydroxyurea are between 10 to 20 pills a week are necessary. 7 pills is 1 a day, 14 pills a week is 2 a day, 21 pills are 3 a day. So most are somewhere in that 2 to 3 pill range per day. And starting a patient, as this one was, at 2 pills a day is a fairly reasonable starting place, particularly for a 49-year-old individual. If an individual is very elderly, or if they have a very modest body weight, then I might start at a little lower dose of 1 a day. Monitoring ongoing hydroxyurea use in a patient with polycythemia vera, I'm looking at several things. One, hydroxyurea primarily helps to control the counts. So that is the main driver. Am I getting them to need less phlebotomies or very few phlebotomies? If they have leukocytosis or thrombocytosis, am I able to normalize those consistent with the ELN response criteria? If there's splenomegaly, does it reduce? If they have symptoms, particularly symptoms associated with higher counts, are they improved? So those are in part drivers of should I be increasing the dose if I'm not achieving those goals up to a maximum tolerated dose or 2,000 milligrams a day. I'm also monitoring for toxicities as I go up on the dose. Am I achieving neutropenia, which would be a dose-limiting toxicity? Am I having cutaneous toxicities in the mouth or skin or on the legs, nausea or other limiting toxicities?